angioplasty was here, my first pacemaker was here, my first BMV was here, my first rescue plasty was here. So Baramati has always been like a second home to me. And it's always a pleasure to come to Baramati. As Pandar sir सांगितलं, I said, sir, as working day, he said, nahi, tu ye. I said, okay, I'll come, sir. Anything for you. So just getting back to our topic, we've all heard about cardiology. What is a cardiologist? So cardiologist is basically a carpenter. He is, if there's a hole in the heart, he'll close it. He's a plumber. If the pipes are choked, he'll open it. If he is an electrician of the heart, if there are arrhythmias, he will map it, find out and treat the electrical abnormalities. If the switches are not functioning well, the tube lightning is not functioning well, so he'll put in a pacemaker, so your heart will function well. So we are all combined, a plumber, electrician, a cardiologist. So today I would just spend more time. We all know cardiology manje in general public is only a heart attack. It's not that. And that's what I would like to spend some time and go through these things that we can discuss. There's a lot of things that is happening in cardiology other than just angioplasty. Even in the field of angioplasty, there are so many new devices which are पकड़ा है you want me to hold it? नहीं करा है fix करना. Invariably, there are always glitches, so I am always scared to be the first speaker because you end up with some issues with the computer and then you are holding the bat. Take your time. I got buddy. Fire, bring a balloon, open up that blockage, and then once that blockage is open, we put a stent and then we come out. But there are a lot of challenges that we face in the lab. The most difficult challenge that we have is calcium. So once the vessel is very calcified, then sometimes the balloon doesn't expand. The balloon doesn't expand, that you can't put your stent in. And if you put a stent in, it's not fully expanded. The patient comes back with stent thrombosis, which is terrible. So there are a lot of techniques that are used for the calcium modification. So the technique, the innovations that have happened is, one, you have balloons, which are high pressure balloons, wherein there are 2 layers of balloons so that you can go up to 40 atmospheres. Normally, you can go to 12 atmospheres. So these balloons will not rupture. They're high pressure balloons. Then you have balloons with cutting, but they've got blades. So you have balloons where you inflate it, that blade will come out of the balloon and will cut the plaque and the calcium. That will help you. Or you can use something called as an angiosculpt, where there are 2 wires which are on a balloon. Again, it's the same way as a cutting balloon. You can use an excimer laser, or you can use a rotational atherectomy or an orbital atherectomy. So these are ones to where you can modify the calcium. So just let me go through a few videos. This is an example of a patient who would be having a road ablation. We did our first road ablation at Baramati. This was a triple vessel disease. So very calcified triple vessel left main. So we did the road ablation. So this is what it does. It's a burr which has got diamond chips at the proximal end. So it ablates only the calcium. It removes only the calcium. So once the calcium is removed, then the vessel becomes malleable. Then the balloon can go in, and then the balloon can dilate that lesion, and then we can bring a stent. The stent is fully expanded. The risk of restenosis. So this is where the stent is going in. Now you can see once the calcium is ablated, you can remove that thing. So similarly, you have an atherectomy which can also take care of that. So this is an example. I'm just showing you 80 years old who had a history of chest pain, and his angiography was done, which showed that distal left main. Is there a pointer? We have a pointer. Okay. So Let me see. So anyway, the distal left main, if there's a blob of whiteness, that is the calcium. And there was disease even in the circumflex as well as the LAD distally. So we took him up for an angioplasty. We did first an IVUS. This is a catheter on the left side, which shows that this is an IVUS catheter. We see the size of the vessel, the length of the calcium, the circumference of the calcium, and then based upon that, we can decide our strategy. These are the IVUS. It tells us the tightest part, which is about 180 degrees calcium here, and it's just 1.75 millimeters. That was the minimal lumen diameter. This is in the LAD. Similarly, we did the run in the circumflex. Once we have staged it, then we took a rotablation burr. We just saw the animation. So we are using this. This revolves at 1,60,000 RPM. We go very slowly because this calcium burrs are broken up. This gets dissolved in the body. We don't want it to go very quickly. We do the burr of 20 seconds so that the calcium doesn't go and cause obstruction. Once the calcium is done, it's been taken care of by the burr, then you can remove it, then you can bring your balloon, and then it's like a routine angioplasty. This is one stent here. Then we also used another stent from the left main to the circumflex. This is a circumflex stent. This is the left main to the circumflex, and this is dilated. And then the circumflex wire and balloon are removed, and this is what the final result is after rotom. But this would not have been possible if we had not removed the calcium, because the first step, the calcium has to be abraded, and then the balloon will dilate. Once the balloon dilates, then it becomes simple with these things. So this is the IVUS post. I'm not going to go into that. So just giving you a comparison of the vessel before here, and this is what the vessel is now after doing this angioplasty with the rotablation and modification of the calcium. So then the other thing that we've heard is about laser. How important is that? Yes, this is a new modality which can use for calcium. You got a wire which is not allowing you to go through. So then you get your excimer laser which abrades, makes a passage. So excimer lasers can be used in acute angioplasty because where there's a lot of thrombus load, it absorbs the thrombus. It can help to remove the calcium also, and then makes a way through this, and then it goes. It's a bit expensive currently. Only a few hospitals have it. In Pune, it is just present in MHCTC, and in Mumbai, it is at Breach Candy. So not many centers have it. But once this is going to be used, it is very useful. Where CTOs, where you have patients who have calcium thrombus, this can help. So my idea here is to just get you all abraded to what you think. Then we have heard about we have lithotripsy for renal calculi. So similarly, we have something called as an IVL, intravascular lithotripsy, to break the calcium. Just showing you a modification that this lithotripsy will only break the calcium. It will not cause damage to the normal one. So this is hard on hard, means the lithotripsy is hard on the calcium and it is soft on the soft. That means the rest of the tissue, which is fibrotic, which is not thrombus, it will not cause any damage. So only if there is a calcium will that thing work. So you must have heard about what is a lithotripsy. So let me show you what is a lithotripsy. So this is basically the same principle. There are emitters here, which is controlled from outside, which emits, and that electrical spark, it's in a balloon which is dilated at 4 atmospheres. You don't go to high pressures. There is saline and contrast in this. So these emitters are stimulated from outside. Once this is stimulated, it causes a bubble inside this balloon. This causes sonic wave disruption of the calcium which is there. So we can control it from here. Emitters go in, that causes the sonic pressures inside that balloon, and that breaks this calcium. You can watch this cartoon. It is breaking only this calcium. So this is at 4 atmospheres only. It only breaks the calcium. It breaks the calcium which is superficial as well as inside the vessel. So once that is done, then again you can do your rotablation. Now you can do your balloon and then get your stent in. This is very useful in case of sometimes you have, this is a combination of both. You can do a rotablation first because this balloon is bulky. So you do a rota, but that has still not ablated the calcium. So then you get this intravascular lithotripsy. This is like what you get for your renal calculi, where you break the calcium. So similarly like that, it breaks this calcium and then makes it very easier for us to take care of the calcium. So this is an example of a patient who he is 82 years old, ex-corporator in Mumbai, in Pune. He came with history of chest pain, antral infarction. So you can see this looks like a stent inside. There's so much of calcium. Normally in an acute MI, we don't do rotablation because that rotablation burr can cause slow flow. So we needed other modalities. Till we had that IVL, we couldn't do that. So in this case, we decided to take this up for an IVL. So you took this balloon, which is now the energy being delivered. The calcium is broken. Then we bring the balloon here. The balloon is dilated. And then once the balloon is dilated, this is, we get our stent inside. And the stent is positioned. And then we inflate the stent. And this is the final result. So this is what it was before, where there's a lot of calcium, slow flow. This is what the vessel is now after intravascular lithotripsy. So this is another modality wherein we can use the to break the calcium. Now, to see how this calcium is, how do you decide whether to use a cutting balloon, whether to use a rotablation, whether to use an IVL? So you need to have eyes inside the artery. So whatever we are seeing outside with an angiography is not very definitive. It doesn't give you the complete information. So it's just like 5 blind men who are feeling an elephant. One is feeling the trunk, he'll describe something else. One is feeling the tail, he'll describe something else. One is feeling the leg, he'll describe something else. But you need to see what it is. So you need to have eyes inside your coronary arteries. That is called intravascular imaging, coronary imaging. So the two current ones that we have, one is called as OCT, which is based upon your light, principle of light. So what we do is here, you get the OCT, you have a catheter, we clear the blood by using the contrast, and this OCT catheter goes in. This is based on principles of light, and then once it is there, the catheter is pulled back. As the catheter is being pulled back, it gives us complete information. So this is how the artery looks from inside. So we can see if there's a hematoma inside. It can tell me this concentric calcium. This is a nodule inside, and this is an eruptive nodules. These eruptive nodules are more prone for your acute coronary syndromes. Then if you have seen a thrombus which is recanalized, so you can see it from inside, it tells me whether this plaque which is there, whether it's lipidic. Now lipidic plaques, if you dilate with the balloon, there's a lot of plaque which is squished outside, can cause slow flow, and it can come back again. So you can use a cutting balloon for these patients, a fibrotic plaque. So similarly, inside the stent, it will tell me whether this is because the stent is not expanded or it is fully expanded. And it can also tell us whether there's inside the stent new growth. The two mechanisms. So you can tell us what this. Now we can see whether there's dissection. The mechanism of angioplasty is by causing dissection. But if the dissection is confined only to inner layer, we leave it. But if it is extending up to the media, it can close the vessel. So in that situation, you need to put a stent. You can see the thrombus inside. So it gives you a lot of information, and you can decide your modality of treatment. So this is how it looks like with the stent view. You can see the bifurcation going into the wires, and then this based upon AI. Whenever the stent, we need to know whether the stent is fully expanded, whether the stent is attached to the wall. So this white line means it is fully expanded. It is attached to the wall. If it is not expanded, this red will tell you that there's some parts that you need to see in this side. So it will tell you whether the stent size is okay, stent is fully expanded, whether there's any dissection at the either end. So the contrast load is better, the patient's outcomes are better, but the risk of stent thrombosis is much lesser with this. So you can see this, you can see it from inside. You're flying through. This is the stent view inside. So called the fly-through view. You can see whether everything is doing well, whether the stent is inside and it's attached to the wall. So it gives you another eye. You're looking at it from inside this vessel. The similar thing. So I'm just going to take you through a history. Mr. Vinay Dixit, he is a 60 years old gentleman, came with an inferior infarction in November, did an angio. There's a critical lesion in the LAD and the ramus. However, his RCA was the culprit vessel, which was causing 100% occlusion. So we took him up for an angioplasty, primary angioplasty, similar, wired, ballooned, and then once multiple balloons inside, a lot of calcium there in that situation, but the balloons were opening up. So there were 2 stents which were deployed. Once that was done, this is the vessel. So there was disease in the LAD, but we didn't tackle it at the first time. So 3 days later, we took him up for a repeat angio. Sorry, this is the first view, and this is what the primary angioplasty. Now it's fully expanded. That is doing well. So 3 days later, on December, we took this gentleman up again. So we checked that the stent is flowing well. We went to the LAD. There's a critical lesion in the LAD here, which is at the proximal part. So wired this, and then balloon dilated. Oops, sorry. Yeah, just hold it there. You can just hold it there. So LAD was dilated and the stent was deployed, and this is what the LAD is. So similarly, we also did the circumflex artery, the ramus, which was dilated, stented, and that was taken care of. So patient was asymptomatic for about 6 months. Then he came back again with the same. So this is the pictures where post LAD, and this is what it is post stenting there in the LAD. So 6 months later, he came back with chest pain, typical chest pain, some shoulder pain. So I said, anybody who has had an angioplasty, you must do a stress test. Did a stress test. Stress test was positive. So we went back and did his angio. So this was in June of 21. So 6 months later. So we did the angio again. So left system is clean. LAD stent is okay. The ramus is also flowing well. So left system was clean. There was no issues with this scar. So we went to the right side. Now when you see on the right side, a lot of calcium, he's got in-stent restenosis. That's here, which is very tight. That's where the two stents were overlapping. There was a lot of calcium which was below that, which we had not modified. We had just done a balloon dilatation at that point of time. So this is where the restenosis was. So in that situation, we did an OCT. We needed to see what is the mechanism, whether the stent is not fully expanded or there's a regrowth, because up to 6 months you can have neoatherosclerosis. So we did the OCT. OCT showed that the stent was not fully expanded because of the blob of calcium which was behind it, which was not allowing the stent to expand. So we went, then the only way that we can now expand it is to break the calcium. Now how can you break the calcium? You have 2 layers of stent. So then we decided to go with an IVL, intravascular lithotripsy. So it's like your regular lithotripsy, what we did. So we got a balloon inside at the site where it was tightest. We went back. There were 2 generations of IVLs. First one, you could give only 3 pulses, 10 pulses of 10 seconds each. Now we can go up to about 120 pulses. That catheter IVL is about 3 lakhs. So you can use it only once. You deliver the pulse, it's over. So you have to ration it well. So we used that, gave delivered pulses. We knew where there was a lesion. Now you can see that this calcium was not expanded. This is where my balloon is. And then we've dilated it. Series of inflations. You can see it here also. There's calcium behind that stent. So then once we've dilated, we have seen, I did a repeat OCT. We can see that the calcium has cracked. I'm sorry for the quality of the pictures, but unfortunately the message I wanted to get back to you was this. So this is where that calcium was not expanded. Now after we do this, it's now fully expanded. You can see that this is now expanded. What was in-stent restenosis, we have now treated the calcium which was behind, and then we've decided then we needed to do some more stenting because there's a new lesion here and there's a new lesion here. So we had to again stent inside the stent. This is the 3rd layer of stent in that. And this, we have now known the imaging. So we knew what was the size. So we went to the optimal size. The previous stents were slightly undersized. So you put in the bigger sizes. Now you can see the vessels. And since 21, he's now undergone his stress test regularly every year. So this is the 3rd year. He has recently finished in April. So he's doing well, no symptoms, and his stress tests are negative. So again, the 2 tools. One is your calcium modification and your intravascular OCT, which tells us, it gave you an information about what this vessel was doing. So similarly, we can use an IVUS. We have also done our first IVUS at Baramati very frequently. We've been doing it now. because again, it gives us an idea of the vessel. It tells us what is the size of the vessel, what modality of treatment can I use to treat that vessel, and then we take it. So here is an example of a patient. This patient is from Gulbarga. He had an atrial infarction. Okay. So he had an atrial infarction. So he had at that point of time an angioplasty with a stent implantation. The stent that was put was 3 millimeters. So which was the last stent, which was okay. 2 months later, he came with chest pain. And then he came to, they did an angio. That angio showed that there was 100% occlusion of that stent, in stent. So they came from Gulbarga to Pune. So we did the angio. In that again, we see that there's 100% occlusion. RCA was subtotal. So we wired that L6. We needed to know what is the mechanism again, because it appeared to be okay. Wired it, balloon dilated because we wanted to see it. So got an intravascular ultrasound. So IVUS study was done. So in that you can see that there is a thrombus in this vessel, and the stent that they had put was not fully opposed to the wall. So that causes stent thrombosis. Normally when you put a stent, the stent has to be opposed to the wall. If there is a gap between the stent and the wall, then the thrombus forms. So the stent has to be fully expanded and it has to be opposed to the wall. So this stent, even though they felt on an angioplasty, on a coronary angio, that was 3 millimeter stent proximal, it was okay. But actually it was a 4 millimeter vessel proximally, and distally it was a 3.5 vessel. So we went back, because once knowing this, we balloon dilated. Then we took a 3.5 millimeter stent inside and deployed it. And now you can see it is better. We did an IVUS. Even on this, you can see that my stent was not steady. There are 2 layers. This is the first layer and this is the second layer. The stent was still not expanded. So if I had left it, he would have come back again with stent thrombosis. So we used with a 4 millimeters balloon inside, and we went to high pressures because we knew from the IVUS that my proximal size of the stent was 4 and distally was 3.5. So we went again with a 4 millimeters balloon, and that showed and repeated the IVUS. Now that the stent is fully expanded, the size is now 11.118. Normally you should get at least 5 millimeters. Here we've got 11.8 and there is no thrombus and the stent is fully expanded. So he is now doing well. So IVUS also will tell you the same, whether stent size is okay, stent mechanism of why the stent has failed, because the newer generation stents are very good. So unless we have not sized it properly or there's some dissection, you usually don't get restenosis. So if you do get restenosis, you need to find the mechanism. So IVUS will tell us, and this is what it was before we started, and this is what he is now, which is now flowing well without these things. So once, this is regarding the angioplasty. Many of these patients come to you who are in cardiogenic shocks. So you need to do these, you need to support the ventricle. You have a RCA infarct, there is a RV infarct. So whatever inotropes you give will not pump the blood to the left side. So these patients do very poorly. So you need some supports. Most of the supports that we all know are of IABP, intra-aortic balloon pump, but it doesn't help us much. It just increases cardiac output by 0.5 ml. So you need something via newer devices which is called as an Impella, and you have ventricular assist device and ECMO. So let me take you through a video of an Impella. What is an Impella? It is a catheter-based balloon pump. It goes into the ventricle. So there is one inlet port here. There's an outlet port here. It is connected to a motor outside your body. So it will aspirate blood from the ventricle and pump the blood into the aorta. So it is unloading your LV. So it helps the ventricle to do its work. Now because it is doing that, the LV is getting relaxed. So, and your cardiac output improves. There are 4 different types of Impella. So one is called a 2.5 Impella. So it increases the cardiac output by 2.5. The other one is 4 liters. The other one is 5 liters. So any one of these things, cardiogenic shocks, post-cardiotomy, if you have pulmonary embolism, so all that also it will help. You have myocarditis, it will help you because it helps, gives time for the muscle to recover. So this is called an Impella. So if you understand this, and can be kept inside, and so this is the inlet and that's the outlet. This is the motor outside the body. It's very small. The catheter is very small, but that helps to unload the LV and gives you time, gives the muscle to recover. So similarly, supports that we have is the LVAD and the right ventricular assist devices. So there are two types. One of them, like all the conditions like cardiogenic shocks, MIs, you can use them, where this is till the heart function improves. That is only till the therapy. The other one is a destination. That means there are patients who have end stage, who need a cardiac transplant. But these patients cannot get it for age or whatever the reasons. So this is called a destination. So you have a ventricular pump, so which is usually placed for the apex. If it's on the left ventricle, it's from the left ventricle here. It sucks out the blood. This is a motor which is implanted in the abdomen, and then it returns the blood into the aorta. So it is called a left ventricular assist. It's a final destination. These patients do well. The oldest patient who has lived so far has been about 15 years on these. These devices, normally with a heart failure, in case of congestive cardiac failure symptoms, the mortality is about 25% per year. So that is very dismal, despite all the medicines. So with this, it has shown that the 80% survival at 1 year, 70% at 2 years. So those patients who are not candidates for a cardiac transplant can also benefit with an LVAD. So, and an RVAD based upon which thing. So LVAD is a destination. That means the final destination. So you can use them for that. So this is a ventricular support. And these are very small ones. This is the pump. This is the inlet. This is the outlet. So they are very small as a pencil size, which are implanted. Needs surgery to implant it. If the battery gets over, you can replace it. They can act longer. They have, of course, their own models. I'm just going to skip this slide. So then we have also heard about valve replacement. We basically, like we always say, is that cardiology is, everything is, as we are going to get non-invasive or relatively less invasive, is always welcome. We always say that lesser the better for infection. So you have a transcatheter mitral valve and aortic valve. So you have multiple things. Just going through a video where you have a percutaneous mitral valve replacement. So you go through the apex. So you have this valve which is across the mitral valve. You go through the apex. This is the valve. This is the opening into the valve which is there. And this is the deployment of the valve in the mitral valve. So this is the valve which is being deployed. And then this is how it looks from below from the apex. You remove it and the valve is functional. So this is a percutaneous mitral valve replacement, which of course through the surgery, but it's less invasive. You would go through the apex and the valve is functioning. Currently the only one device which is approved by FDA is for mitral regurgitation is a Mitra clip, wherein you catch if there's significant mitral regurgitation, you don't need to go for surgery. You need to replace it. How do we do that? You get the two valves which are there, they clip it. It holds the two leaflets and that reduces the orifice of your mitral valve. So that reduces the regurgitation and that reduces the left atrial dilatation and subsequently the left ventricular dilatation. So this is how it looks. A bigger opening is now looking very small because of the mitral clip. So this is done percutaneously from the venous approach. So you don't need to worry much about the trauma. So this is how it is catching it. So it is clipped. It's like your regular cloth clip that we use to hang our clothes. So we are hanging our valves in this. So this is where the mitral cap reduces the orifice. And you can use one or two. This is the current one system which is FDA approved. This is a mitral clip. And we have all heard about TAVI, is where this percutaneous aortic valve implantation. So where we don't need to do surgery. So we are getting multiple valves. So you crush the valves and you put a valve in the aortic position without doing any surgery. It's done percutaneous. It's about 30 minutes and you are done with the deployment of this valve. This is a balloon implanted valve deployment. This is fully deployed and then the patient is out. This is usually done for, patients who are 80s and 90s. You cannot take these patients for surgery. So percutaneous aortic valve implantation, TAVI, and Mitra clips can help you without going for surgery. and it is equivalent to your surgical equivalent and with less morbidity. Then we have most common problem that we all face in our daily practice is hypertension. And you see a lot of patients who are refractory to hypertension. You have 3 drugs, 4 drugs, diuretics, still the blood pressure is very high. So we have a new therapy for this, which is called as renal denervation. Around the renal arteries, we have sympathetic nerves, so which can cause our pressures to increase despite working. So we have a procedure which is called as an RND, wherein we have a catheter which is placed in the renal arteries, which is maneuvered from inside and outside, and we give radiofrequency ablation, like how you do radiofrequency ablations for EP studies. So you can do these ablations to this at the sympathetic plexus around the arteries. Very simple procedure, and you can deliver it into the artery. It does not cause renal artery stenosis. People are concerned whether this can cause renal artery stenosis. So that about 20% of the patients after doing this are completely come down on the doses of the antihypertensives, or if they were responding to about 3, 4, 5 drugs, you now come down to 1 or 2 drugs, which is also a very important for that patient, because you don't have to take so many and the risks come back. So this is called as renal denervation, which is also being used. So this is so that we all know that this therapy